Thank you so much. There are as many full-time pediatric IRs in the UK as there are people who have walked on the moon. And the answer to that, in case you were wondering, is 12. We are a pretty rare breed, so it's an absolute pleasure to have been asked to come and talk a little bit about my favourite subject at your excellent meeting today. Why is it? Let's have a little think about why people wouldn't go into doing paediatric IR. Well, this is kind of maybe your typical patient that an adult interventional radiologist would be comfortable treating. And this would be a complete nightmare to me. I'd be really uncomfortable with this size patient. And someone like this is far more the kind of challenge that I'm used to facing. However, on the other side of the fence for adult IRs, it's the other way around, of course. And having to treat a patient this small would be a pretty challenging day for most IRs. You can see why it doesn't look a particularly tempting specialty right from the get-go. Surely there can't be any other reason why you wouldn't go into it. It surely couldn't be the patients, and it couldn't be the parents, could it? Although actually I can see, looking at this image, why this is quite an intimidating idea, being a young doctor and having to speak to parents who are handing over their most precious possession to you for you to perform an intervention on. There are other challenges as well in paediatric IR. So this delivery device in the package here on the bed, you can see, is a biodegradable tracheal stent. It's 7 or 8 millimeters in length. And this is what it looks like from the other end when you're about to deploy it. So this is the size of the delivery device. And on the end of this is that tiny stent that you've got to place in exactly the right position in the distal trachea, just above the carina, not into the left main bronchus. And that is a pretty big delivery device in which to be doing that. Industry hasn't really developed a lot of kit for very small babies and toddlers, in large part because of the numbers involved. There's a lot more adult intervention going on across the world than there is pediatric. So for a lot of the time, we are left to use kit like this that isn't made for patients of the size that we treat. But equally, I see that as an interesting challenge, that we get to be quite innovative with the devices that we use and the kit that we have available. And hopefully I can show some examples of that for you today. Some people have concerns that if they go into a subject that is such a subspecialty where there are very few people around, it's quite an isolated career path and you're going to feel quite vulnerable. Well, the situation is changing in the UK. The fact that we're here to talk to you today shows that we finally made it onto the big stage. And actually, although there may be very few of us doing this full time in the UK, there is a growing network of people who are really interested in and doing more pediatric IR. And there's an even bigger international community out there that we'll talk a little bit about later. People always also worry that there may not be jobs out there if they choose such a niche specialty, but actually we are working exceedingly hard with the college, the BSIR and various other organisations across the UK, as well as individual trusts, to increase the number of training posts and also the number of consultant jobs that are out there. So this scenario is changing too. So if you decided to step out there and become the next paediatric interventional radiologist for the UK, what would that job exactly look like? This shows the kinds of procedures that we do in our department on an annual basis. And you can see there's a huge breadth of experience and possibility here. What's interesting in paediatric IR, where there are so few of us, is we really don't have the luxury of deciding to subspecialize within that area. So none of us would say that we are just a vascular IR or non-vascular, that we only do hepatobiliary, for instance. We have to be a jack of all trades and hopefully a master of most of them as well. And certainly within our institution, even though there are 6 of us working full-time in paediatric IR, we'd all be expected to know how to do all of these procedures. And I love that every day is different and you will jump from one procedure to a very different procedure all within the same day. This is a child who had a very large right-sided renal stone that has been removed after a PCNL. That's a minimally invasive way of drilling a very small hole through the back into the kidney and removing the stones percutaneously. We're going to talk about PCNLs in the workshop this afternoon. So this is really the gold standard for removal of renal stones in patients across the UK and internationally too. This is what I would want for myself or for any of my family, and it's what you would want for yourself too, rather than major open surgery with all the attendant risks that brings, as well as the potential for long-term renal scarring. So this child was given that opportunity and has had his kidney stone completely removed and made an excellent speedy recovery just over 2 or 3 days after this procedure, and went home 4 days later. But even in the UK, not every child with a renal stone is offered this kind of procedure locally, and may not be offered it at all. What's exciting about doing paediatric IR is being able to give children and families the opportunity to access gold standard state-of-the-art procedures, minimally invasive procedures that we would want for ourselves, and changing the landscape of treatment for children in the UK is what really excites me and keeps me going back to work each day. One of the other great things is that all of our patients are asleep, or pretty much all of them. So all of the complications of really, really sick children and all of the complexity of dealing with them, as well as the more as the other aspect of it, of having to reassure and explain to patients everything as you go along, all of that is taken away from you and dealt with by the anaesthetist, and you can purely focus on what it is that you're trying to do technically. Children are incredibly positive. They are such an amazing population to work with. They don't want to be in hospital. They just want to get up there and out there. And on a ward round, they're much more likely to tell you about the pizza they've finally just got to eat, or the drawing that they've just done for you, than complaining about the drain or the size of the wound, or asking you how many stitches they've got. It's one of the joys of doing paediatric IR for me, certainly. For those of you who are thinking hard about it, most children do very well after trauma, for instance, and certainly the on-call for paediatric IR is super quiet compared to some of the adult on-call out there. I hope I'm beginning to sell it to you now. And finally, these are paediatric surgeons. There really isn't much of a turf war in paediatric IR, unlike there may be in some areas of adult IR in some institutions. Paediatric surgeons have still to really pick up on what it is that we do, and they're quite happy to let us get on with what we're doing, certainly in any of the institutions that I know of in the UK. I think that's a real bonus. Let's talk a little bit about what we do as paediatric IRs. Well, there are several aspects of it. Part of it is just being there to assist the rest of the work going on in the hospital, to ensure patients get their gastrostomies, their central lines, and everything else that they need to support the other services that are going on in the hospital. Some of it is diagnostic and investigative. Some of it is treatment. But most excitingly, some of what we do is really, really innovative, developing new procedures and bringing them to fruition in the hospital in which you work. Let's look at each of those in turn. Let's start at some of that supposedly very simple supportive stuff. These are pictures that show the dilemmas and the traumas of peripheral venous access in children. The child on the right has totally run out of peripheral veins and is having to have a scalp vein used for his cannula here. But actually, this is not what we should be seeing. And if we're offering a good line service in a paediatric hospital, we can ensure that children like this chap here, who needs a reliable line for his hemodialysis, and this patient who needs a nice, easy line for access for chemotherapy, can get those lines, and the children and the families who are going through all this other stuff and have got plenty of other things to focus on can get on with it and focus on those other things and not be worried about the endless cannulations, which for some children can just become the complete focus of their admission and scar them physically as well as emotionally for life. There are lots of central venous access devices out there. And in our department anyway, we were able to place all of these. We also have two specialist radiographers who work in our department and do a lot of the vascular access with us. And these might be central tunneled lines, as you can see on the left-hand side there, or they might be peripherally inserted lines, such as the PIC on the right. This is how historically these lines were placed by the surgeons, with an open venotomy in the neck, quite a large scar, quite a lot of handling of the vein. You can see in these images here. And the trouble is that with a lot of open venous access like this, the veins just get lost. So the children run out of central veins after quite a short time if they have had multiple central lines placed, those children with chronic disease and other things going on. And really, it was shown a long time ago that doing vascular access through a minimally invasive percutaneous technique using image guidance is far better. And actually this was recommended by NICE way back in 2002, that all central venous lines should be placed using a minimally invasive image guided technique. You can see using the ultrasound probe like this, the internal jugular vein and the common carotid artery are beautifully seen. In fact, in children, you can see even more than just those veins. This is scanning from above the clavicle, but looking down behind the clavicles, and you can see everything here, the brachiocephalic veins and even the SVC. You can see on the image on the right, you can see the needle tip within the brachiocephalic vein itself. For the puncture, you can see the needle coming in from the left here, indenting and then puncturing the internal jugular vein. And then through a guide wire and a dilator, we're then able to feed the line over that and place it at the level of the right atrium. The advantages of image-guided percutaneous techniques like this are that they're safer because there's less bleeding. They're much, much quicker because you're not having to explore the neck and open the vein. There's a higher success rate because you can pick your vein before you start. There's a better cosmetic result, the scar is smaller. There is some evidence to suggest there's less early infection because there's been less manipulation at the operative site. And most importantly, I think for children with chronic disease, there's improved long-term venous patency. And you can see some data here. This was a study we did many years ago. We looked at the surgical group versus the image-guided group. And by surgical group, I mean open venous access procedures. And the vein occlusion rates were statistically different by a large margin in the image-guided percutaneous group. Sometimes we're faced with patients like these. They've had lots of central lines placed either in our hospital or in other hospitals, and they come to us like this. This patient's had contrast injected from both upper limbs. You can see it filling collaterals in the neck, and there's no contrast making its way down into the heart. This is what that neck would look like, the left side of the neck, for instance, on ultrasound, a patent common carotid artery, but echogenic thrombus filling the lumen of the internal jugular vein. And you can see with the arrows there, lots of very small little collateral veins trying to carry that venous return through other channels. In this patient, we've punctured a collateral in the right side of the neck. The contrast has gone north rather than south, so we've punctured again higher up, and you can see that tortuous collateral there, but we've managed to get a guide wire all the way through that collateral, followed with a dilator, followed with the catheter, and placed a Hickman line through it, as you can see here. Nice and easy. This one was a bit more challenging. This is from the groin. These are the obturator veins because the common femoral veins had gone. And I think you can just make out the details of the pathway of this port catheter here. We've placed the port reservoir up on the chest wall as per normal, but this really long catheter has been tunneled all the way down the chest wall to the groin. And then through all of those collaterals, the obturator veins, across onto the other side of the pelvis, into the left internal iliac vein, and up towards the right atrium. But this catheter stayed in for many years, and this child did really well. Other options are perhaps even more heroic. This coronal image here shows you that actually if you puncture the hepatic vein, you've got a direct shot straight to the right atrium. And you can see on these frontal and lateral views here, we've got a transhepatic catheter in situ. Not a great option and one we would try to avoid, but one that you can use in children who run out of all other venous access options. Finally, we could decide just to recanalize these vessels at the top end that are occluded. Again, we've injected contrast from both upper limbs here. You can see the left brachiocephalic vein here is patent, but the right brachiocephalic is occluded, and the blood from the right is returning via lots of collaterals. So we've gone on to image that a little bit more closely. We've managed to work out exactly the distance we need to cross. And with a bit of effort and a bit of good luck, we've managed to cross that stenosis with a guide wire. We've then put a metal stent in, I think you can just see there, and ballooned that up. And we've now got beautiful through and through access and normal venous return, not filling the collaterals, and now heading right to the right atrium. A really satisfying procedure and something that will give this child reliable venous access, hopefully for many years to come. Those are some of the supportive things that we do. So let's have a little look at some other things that are more investigative and diagnostic. Some of it is very straightforward. This is a right-sided renal tumor in a toddler. We would be asked pretty routinely to come and biopsy lesions like this. This is a diagnostic angiogram showing very, very abnormal renal arteries bilaterally in a child with fibromuscular dysplasia of the renal arteries causing hypertension. And we can show those images in a much more beautiful way here, which the surgeons really like. It really helps them and us to work out what are the best vascular options for these patients. Doing procedures on very small children like this is a challenge. You can see, I think, from this picture how sick this child is. The abdomen is hugely distended by this liver tumor here. And you can see the central vessels showing the massive blood flow through this lesion, and this child is in cardiac failure. So there are a lot of things to think about when approaching this case. We need to think really hard about how much fluid we use, because if we use too much contrast or saline flush for these runs, we're going to further fluid overload this child into further crashing heart failure. But it was really important that we got these angiogram images here. For all of these images here, we have only used about 2.5 mils of contrast for the entire study. And we've got really good imaging of what's going on in this liver and what needs to be done about it. In an older child here, we've approached that really differently and used carbon dioxide angiography instead of fluid contrast to image the aorta here. Really beautiful pictures. This means the kidneys aren't knocked off by using iodinated contrast, and we're not fluid overloading the child. Finally, this is another child with a liver tumor here, again in cardiac failure, and we've used CO2 angiography on the left-hand side to image the center of this shunting lesion, and then gone on to use contrast when we've actually done the coil embolization. Finally, I thought these might be interesting pictures to show you. This is a child with an airway issue, and you can see from these images here, we've put some contrast down through the ET tube, how floppy that trachea is. This is tracheomalacia. This is what it would look like down the stent, down the bronchoscope, really floppy and compressed on an AP dimension. And on this lateral view here, you can see here the really floppy central portion of the trachea. We've put increasing levels of positive pressure through the airway here, and you can see as we've gone up on the pressure from 5 to 10 to 15, how that trachea has opened up beautifully, and that gives the respiratory guys a lot of information about how easily they can overcome the floppiness in this trachea and how they can treat it. This is a child with long segment tracheal stenosis, a very, very long, narrow trachea there. And we further investigated this by using something called optical coherence tomography. And you can see here what these images show. On this left-hand image here, this is a normal trachea, and you can see just the horseshoe appearance there of the cartilage in the front wall of the trachea, rather. In this patient, can I convince you that the cartilage ring goes all the way around, and these complete cartilage rings are what cause long segment tracheal stenosis. The surgeons need to go in there and find every single ring and divide it, and us being able to do this procedure down through the trachea for them allows them to map exactly which bit of the trachea needs operating on. It's really exciting stuff and really innovative. In terms of treatment, this is very straightforward. This is a child with an esophageal stenosis here following surgery for esophageal atresia. You can see contrast in the dilated upper esophagus here. We've put a balloon down and dilated up that narrowing there in the neck, so that in the upper esophagus, so that this child can eat and drink again safely. And at the other end of the spectrum, a little bit more complicated, this is a 13-year-old boy with ALL, with leukemia, and an associated hyper-eosinophilic syndrome. This makes them very likely to form clots in their bloodstream. And this child has developed left external iliac vein thrombosis. You can see there's clot in the vein here, and an IVC filter has been placed. But that clot has continued to form, and so we've had to go in and clear that clot. You can see we've driven something called an angiojet device up there, which chews up all of that clot and gets rid of it. And we've re-established inline flow from his left leg through that left internal iliac and back through to the IVC. Really nice case. Finally, this is an 8-day-old female with meconium aspiration who developed pulmonary hypertension and required ECMO, which is a complex form of bypass that's quite very high risk for children. And there are not many ECMO beds available in the UK. You may have heard a little bit about it recently, some COVID patients going on to ECMO. This child has developed an air leak on the right after a traumatic lung injury following intubation over a wire or a plastic dilator of bougie. So they've developed a bronchopleural fistula, and this is really, really difficult, often with a child who's ventilated, to sort out, because the air is being pumped through the fistula, and that leak is never going to resolve on its own. Normally, the respiratory doctors have to go down and do a scope through every single one of those segmental bronchi to find the leak. So we just put a catheter down and injected some dye. You can see this is a normal segmental bronchus with no leak. But on this one here, you can see there's immediate leak of contrast from the catheter through that bronchopleural fistula into the pleural space. Here's another image of that. We've gone down with a microcatheter and injected some glue. And 36 hours later, this is her chest x-ray. The air leak's gone, the lungs come back up again. She was decannulated, or otherwise meaning removed off ECMO 36 hours after the procedure, and discharged to her local on conventional ventilation the following day. And this was pretty innovative. We'd never tried this before, but it worked beautifully. Finally, this is what I mean. We get to do really, really innovative stuff in pediatric IR. Because it's such a new and evolving field, there are so many things that have never been tried before. Here's an example. This is an old film. This is a little girl who at this stage was 7 months old and developed a viral infection which affected her heart. You can see how enlarged her heart is there because she's developed a dilated cardiomyopathy. And after this x-ray was taken, her heart continued to dilate. She was in a really, really bad way. The heart obstructed her left main bronchus and her left lung collapsed and then became infected. So although initially she was felt to be a candidate for heart transplant, because this is not thought to be reversible disease, she was then not eligible because of the long-standing infection and was taken off the transplant list. We were asked if there was anything we could do to try and get that left lung back up again, to palliate her, make her feel better from her lung infection, to get her home, not for transplant. So we thought quite hard about this. The trachea is at the top of this image. You can see contrast filling really nicely the right main bronchus and its segmental bronchi, but no contrast into the left lung. With a bit of effort, we've got a guide wire to cross that compressed left main bronchus, and we've placed a metal stent across it. We didn't know if that would work. You can see it there on the CT. We thought maybe the pulsating heart might collapse that metal stent, but it didn't. Over a few days, that left lung came back up again, and over the next few months, she cleared her infection. And in the end, she was deemed well enough for transplant, but actually everything about her continued to improve. And in the end, she was deemed too well for transplant. She's now 12 years old, still with that stent in situ, but doing really well and not needing a cardiac transplant at all. Finally, this little chap here has got quite an unusual benign lesion of his left shoulder. This is a lymphatic malformation, but quite a solid one that we've tried treating with other conventional interventions, and it hasn't worked. You can see the disfigurement he's got, the pain he's in, and this lesion is so big and involving so many structures, the surgeons were not keen to get involved. This would have been really disfiguring surgery. We thought, what else could we use to shrink lumps? And we knew that cryoablation, where you freeze tissue in order to shrink it, is something that's used to treat lumps and bumps around the body, most commonly renal cell carcinoma, but other diseases as well. And we thought perhaps we could try cryoablation for this as well. This is him on the day of surgery from the back. This is the lesion here. And this is him from the back and also from the front 3 months later. You can see how that lump is almost completely resolved after just one ablation treatment. This was one of the first cryoablation treatments we did in our institution with an amazing result, and he's still doing really well 6 years out. So that's a brief whiz through some of the great things that that we do in our specialty, and why it's so exciting being one of the few people doing this in the UK. I hope it's inspired you to think about stepping out there and maybe coming to have a bit of a taster session with us and see if it's something that you'd like to be involved with too later on in your careers. If you're interested, there's an annual PAEDS IR UK meeting in Manchester. It'll be online this year, but face-to-face again, hopefully from next year onwards. Look out for that. There's also an International Society for Pediatric Interventional Radiology, and this organisation is free for students to join, so please think about doing so. I'd be more than happy to support your application. Please get in touch with me if you've got any other questions or want to find out more about it. And I'm happy now to take any questions if anybody has any. Thank you so much.
Thank you, Dr. Barnacle. That was excellent. We do have a question for you, which is, do you anticipate straightforward pediatric IR procedures being offered at DGH in coming years, or will it remain a tertiary centre specialty?
Thanks, Helen, and thanks, Niall, for the question. Good to see your name popping up there. For those people at the event who are not from the UK, DGH is a district general hospital. And Niall, I think you're absolutely right that we do need more of that. And that's why you don't have to be a paediatric interventional radiologist at a tertiary or quaternary centre just doing this. What we need to do is have a whole network of people who are trained up in doing the more straightforward stuff, because not every child and every family should have to travel a long distance to get relatively simple procedures done. We just need to break down those barriers of fear and uncertainty as to the, people think that a lot of this stuff is super difficult, but actually adult IRs are incredibly skilled, far more skilled than we are, I'm sure. And they do have the skills. It's just giving them the confidence to use them, knowing what kit to have on the shelf, and introducing pediatric IR, I think, earlier into training, and us being on the platforms with adult IRs at all sorts of different meetings just will increasingly make us feel more mainstream, and that's the direction we should be heading in, I think. Yeah, great question.
Thank you for that. Do we have any other questions?
I have a question for Alex. Alex, well done. I'm about to change my career into pediatric IR. So what would be the pearls of wisdom for all the medical students out there to entering this career?
So I think just even the talks we've just heard this morning show that interventional radiology is such a broad field, isn't it? In some people might be tempted to think that it's a pretty narrow specialty of radiology, but actually there's such a wide world in there once you look into it, and there's something for everybody. I hated IR in my training. I absolutely hated it. I had a background in pediatric radiology, and I thought, I'm going back to, ultrasounding dilated kidneys again. That's so much nicer than this. But it wasn't until I started doing it in pediatrics that I suddenly realized it was fun. And I changed my mind 4 or 5 times over, not only just during my career, but during radiology as well, as to what I wanted. And even once you start in interventional radiology, you can move around. You might decide vasculars for you, and later on, not so much. You find other interests. To think that you know at the age of 25 or even 35 what it is you want to do for the rest of your career, I'm guessing Z would agree, is simplistic, because your experiences change. And yeah, go out there and see a bit of everything, and don't think you need to tie yourself down, I think is what I'd say.
I think Alex just showed that how amazing the spectrum we can do, and I certainly genuinely touched by all the miracles you have performed on all these children. Really am. So thank you for sharing them.
Yeah, thank you so much again. It's an honor to have you.
It's a pleasure. Thanks for the invitation.
Thank you.
Thank you.